So as Dr. Shaker mentioned, my name's Sarah. I am the Inpatient Fracture Liaison Service Coordinator. Going to be talking to you about what it looks like when I see patients immediately post-fracture. My intended audience for this is really those people who are still potentially in the planning phase of their FLS, or maybe those people who are currently doing inpatient evaluations and just struggling to make those meaningful connections with their patients to get them to be able to follow up. So hopefully whatever phase you're in, there's something in here that you can take away a little bit to help you on your FLS journey. I have no disclosures for today's talk. My objectives today include identifying the different FLS models. Not all FLS models have an inpatient evaluation embedded into them, so I will review the elements of what I do when I look at a patient on the inpatient side. We'll talk about what we've found here at Froedtert as the benefits to that. We've definitely identified limitations and barriers to that, so we'll go over that. And then lastly, we'll talk about how to maximize your time with the patient so that you get the most from that consult, and how to use the fracture as a teachable moment for them. So the literature really identifies these four, they call them the 4 I's of an FLS model, which include identification, investigation, initiation, and then improvement or monitoring of adherence. The first type of FLS model is type A, and this is really your most intensive or your most comprehensive FLS model. It incorporates all 4 I's, and the FLS is really involved from start to finish, which includes initiation of treatment and monitoring of adherence to that treatment, and then looking for ways to subsequently improve that treatment and monitoring. Your type B models really only differ from your type A model in that the treatment initiation becomes the responsibility of the primary care provider. So you in the FLS, you might still make a recommendation, and then the PCP does the treatment, and then you might monitor for adherence afterwards or be in a supportive role after that. Type C models are less intensive. The purpose of the FLS is to identify the patients, provide lifestyle education, and then their role is to really alert the PCP to the need for further assessment and treatment. But really after that, they're not doing anything in terms of monitoring of adherence. The type D model is the least intensive, revolves around education only, and then any sort of subsequent follow-up becomes the responsibility of the patient to initiate that assessment and treatment with their PCP or whatever their healthcare provider might be. So to talk a little bit about the model that we've created here at Froedtert, we most closely mimic a type A model. This is just this diagram here is just a really high level overview of what we do here for our Froedtert FLS model. Last meeting, you guys were able to hear from my outpatient partner, Aaron. The difference between Aaron and I is I really focus on this identify and this investigate piece. And then my ultimate goal is to get that patient the appropriate follow-up that they need. So I myself do not do any sort of initiation of treatment on the inpatient side. And we will definitely go in and talk about that a little bit more. So when I see a patient immediately post-fracture, I'll talk a little bit about how that workflow looks. So patient is admitted with a low trauma fracture, and then an order gets placed for our inpatient fragility fracture liaison consult. What we've done to make this more successful on our end is we've built it into our ED hip fracture admission order set as a default selection. So anytime a hip fracture comes in to the ED that gets admitted to the hospital, this is an automatic consult that they'll see. So that saves me a little bit of time on having to search for these patients. And it's definitely been one of the ways we've been more successful in being able to capture these patients right away on the front end. So in my role, I monitor this consult list daily. And then I'm also able to look at the floors and identify those patients that maybe weren't a hip fracture, but still some sort of low trauma fracture. And then at that point, I reach out to that patient's primary team and request a consult, letting them know that the patient has met fragility fracture criteria and they would benefit from a bone health consultation. I do try to see operative patients around post-op day 2 to 3. And I've just found that that works best in terms of where their pain management is, anesthesia effects have worn off, and any immediate surgical post-complications at that point are more likely to be under control. So I found that that's sort of the sweet spot on me being able to have a more successful consult with that patient. Here at Freighter, we have a pretty wide inclusion criteria for our FLS. We try to make it very easy on our providers on knowing when they should maybe include us and when they would not want to include us. We often use the phrase, Erin and I say all the time, that there's no bad consult. We're happy to see these people. We will get them to where they need to be. And that they should let us be the easy button. And if you are thinking about a bone health consult, just go ahead and put it in. And if it's maybe not appropriate, we'll get that patient to where they need to be. So we will take any low trauma fracture requiring admission to the hospital. And then also what we've been doing is taking consults from our orthopedic team when they are identifying poor bone quality intraoperatively. Even if it is a more high velocity fracture, it's something that they'd like us to look into. And oftentimes we do find that there's something that we're able to help manage for that patient. The only true really hard stop exclusions that we use for our FLS criteria are bony metastases and end-stage renal disease, and those are for pretty obvious reasons. So to go into a little bit about what I do for the inpatient evaluation, we do have a set of bone health screening labs. Now these labs are, I would say, probably not available more often than they are available. These are only drawn if we're able to get them done prior to surgery. And how we've done that is, I mentioned that our consult order is worked into the ED admission order set, but also these bone health screening labs are worked into there so that the patient, while they're in the emergency department, those ED nurses are drawing these labs for us. And really, I'll go into this as one of our benefits, but what we've been able to find with this is that allows me a much clearer picture if there's any immediate secondary causes for osteoporosis that might lead me down a path of wanting to refer this patient to endocrinology right away versus having them follow up in the bone health clinic. But even in the absence of any labs that I might have specific to bone health, I do complete a high-level screening for secondary causes. And I do that just through a thorough medical history with the patient and a thorough physical exam, and talk with the patient to identify if I have any concerns or sneaking suspicions about a secondary cause. And then again, I use that to make decisions about how I want to set up their follow-up plan. I then provide education, and this really revolves around those modifiable lifestyle things like smoking, alcohol. I complete a 24-hour dietary recall so that I can make recommendations for calcium supplement if needed. We will start patients on vitamin D if they're not on something. We'll go over weight-bearing exercises. Here at Freighter, we have an osteoporosis PT program that I like to kind of set the stage for our fracture patients and let them know that after we complete fracture therapy, this is another type of therapy that we might consider for you. One of the biggest things that I think I spend a lot of time doing, so we do not use delirium or dementia as an exclusion to our FLS. And so I do spend quite a significant amount of time connecting with patients' family members. And I think what I've heard from Erin on the outpatient side is that even if patients don't remember talking to me, their family members might. And so I never discount this, and I always try to take the time to make sure that I'm following up with their family members. And even if the patients are alert and orientated, I will ask them, is there somebody you want me to call to talk about this follow-up plan with, so that they can help you get this done. The next thing I'll do is I really try to coordinate with our other healthcare providers, and that can mean a lot of things. That can mean the patient's primary care provider. It can mean our endocrinology partners. It can mean sometimes our hematology and oncology partners. We see a lot of those patients who have a prior leukemia or something that we're trying to treat for them. I always make sure that if the patient has not had a DEXA within the last 2 years, that they leave with a script to get that done. And then the biggest task is to make sure that they have some sort of follow-up appointment arranged. Most often we get that done by me referring out to my partner, Erin, but we will make that work in whatever way the patient wants. So some patients prefer to keep with their PCP, and we try to honor that when that's appropriate. As I mentioned, and as Erin talked about at the last meeting, if there's a concern for secondary osteoporosis, we will refer out to endocrinology, and I do try to speak to those providers and let them know what I saw and what I'm concerned about. And then, of course, talking with the patient's oncologist if needed to make sure that they don't have any questions or concerns. And some of our oncologists have also started taking on kind of this osteoporosis and have already started some sort of treatment for the patient, so then I try to connect them there too. So by doing this, where we have an inpatient component that meets the patient immediately after fracture, what have we learned from this, and what have we found the benefits to be? One of the biggest things is that we're able, as a patient satisfier, we're able to get the patient to see the appropriate provider the first time around during follow-up, versus having them, and it still sometimes happens, but we're able to reduce that, versus having them follow up in the bone health clinic and have it be something that we're really not going to manage within the FLS, and it's something we have to refer out to. So it avoids us looking like we're passing the buck to the patient, where we get them to the right place the first time. It allows us to optimize the calcium and vitamin D right away. We know that before we start treatment, these are two things that we want to make sure are taken care of. So if I can get the patient on a good calcium and vitamin D regimen for 4 weeks, that potentially eliminates any sort of delay to treatment related to these items. The other thing we found is that sometimes, especially in our the oldest of the old patients that we see, calcium and vitamin D is all they want to do. And so we take that as a win too, if we can just optimize those things for them. We find that it's been a highly coordinated approach between Erin and myself. I'm able to let her know what my experience was with the patient and what their concerns were, and then I'm able to pass that on to her so she can ask about that in clinic and make that a seamless transition for the patient. So as I mentioned, it allows us an opportunity to connect with families who can help with this follow-up. And then we've really heard from patients at the bedside that they feel supported and that we're really thinking of their care from all angles. So some patients have said, wow, and I didn't think about that, but thank you for talking to me, and they've been relieved that somebody's addressing this part of their care. It also allows for multiple points of reinforcement for those patients that are maybe potentially resistant to this idea that they do have bone loss going on. So I can sometimes be that conversation starter, and if I can just get them into clinic with Erin, they're sometimes more willing to have that conversation. And then it also allows me the ability to actively seek out new referrals by monitoring the other floors for those low trauma fractures that might be coming in.
And we're at 5 minutes.
Okay, thank you. There are definitely limitations to this. Patients are really overwhelmed after surgery. There's a lot of unknowns after surgery. You're also competing with things like delirium and surgical complications and their rehab needs. So sometimes you want to come in and you want to talk about their bone health and their osteoporosis, and they just can't make it there with you. If you're like our institution, there's a big focus on shortening our length of stays. So it's, again, all about finding that sweet spot where the patient is able to have a conversation with you, but that you're not doing it like at the final hour before they're getting wheeled out the door. And really, I know this is, I don't find it to be controversial, but I know that there are other FLS models out there that are starting to push the envelope on when they start drug treatment. But really, inpatient space is not the time for drug treatment initiation. It just doesn't allow a sufficient ability to rule out those secondary causes. Then we know that after fracture, one of our first-line drugs should be our anabolic agents, which require insurance authorization with things like zoledronic acid. You don't want to have the acute phase reaction occur after any sort of surgery and have any mix-ups about like, oh man, is this patient now experiencing some sort of infection after surgery? So those are just some of the reasons, but for a lot of reasons, the inpatient space is just not where you want to be starting somebody on a drug. So using fracture as a teachable moment. My biggest emphasis is be prepared with a toolkit and have multiple resources available. Know walking into that room that you might be the first person to tell them that there's a problem. I've heard Dr. Binkley speak on the bone attack and many others, and I find that that's been a useful tool in my toolbox as well. I also like to describe what's normal for our skeleton, and I tell them that after a fall from ground level, our bones are really meant to protect us from something like that. And when they don't, that's an indication that something's going on. Always reference their function, mobility, and independence and what multiple fractures can do to those things. And emphasize, a lot of people want to know, well, I just thought this is part of aging and that this is normal. So I always emphasize that this is not normal. It doesn't have to be their story, and that we do have treatment available. Always be prepared to debunk any myths. There's a lot of people out there that will ask me up front, well, what about these drug side effects? People know about ONJ and AFF, so be ready to debunk some of that. I like to use radiographic evidence when it's available. So if I have a report saying that, there's diffuse osseous demineralization, I use that as a tool to talk to the patient. And lastly, worst case scenario, if I just can't help that patient be there, saying, yep, okay, I think there's a problem, I always then just say, well, let's just get the DEXA and see what it says, and we'll go from there. And oftentimes then people are willing to at least do that. So just some additional tips for success. Start small, start with one population like hips. Don't let perfection be the enemy of good. This was our surgeon's kind of call to us. He always told Aaron and I, whatever we do is going to be better than what we're currently doing because we are currently doing nothing. Make sure you're maximizing your EHR. We have lots of templated notes. We have built-in order sets, and those things have helped us to be much more successful. And then lastly, use multiple forms of communication, not only when you're talking to patients and their families, but also with providers, especially when passing off a patient. So whether that be inbox messaging, email, fax, telephone calls. I've kind of found you can't over communicate about something like this. So that has helped me as well. Be sure you're making connections and utilizing all your resources within your health system and what you have available to you as well. These are my references. This is my contact information. Happy to chat with anybody and take any questions then.
Okay, thank you very much. That was a nice presentation. A couple questions. One, we struggle with patient follow through with therapy. What percent of patients you see follow through with BMD and treatment if needed?
Um, Erin, you might be able to chime in on this too, but with this model, we've been pretty successful in seeing a good rate of um, uh, success with BMD and treatment. I think when you compare us to like that national average of like around, what is it, 20% of patients who actually get treated. When we pull data from our actual program, we sit around probably 60% that we're able to do. So we've been pretty happy with that number. I will also say we are an Own the Bone enrolled site, and that has also proven to be very helpful for us. With that, we have patient letters that we send out, and we've sort of staggered it. So I will see the patient on the inpatient side. I will wait a while and allow that patient time to convalesce through their fracture care. And then I will send a follow-up letter saying, hey, remember, talked in the hospital, and this is what we want you to do. If I see that they already have their BMD done or they're already on Erin's schedule, then I will use it as a reminder. Like, thanks for getting that BMD done. Don't forget to see us at this time at your clinic appointment. And that's helped too.
Okay. We have attendees congratulating you at 60%. I think that's fantastic. Do you rely on primary care to refill meds and continue treatment after it started?
No, once a patient is enrolled into the bone health clinic, once Erin initiates treatment, she will manage and handle all refills from there on out.
Okay. One more question. Do you know what percent of hip fracture patients are in treatment within 6 months? I think the national data might be about 20%. And do you think you've done better?
It's a good question. I don't know that we have been able to have any like solid data pulled. Of course, I'd like to think that we're performing better than that, but I don't know. Especially with those hip fractures, we sometimes find that they sometimes do take a little longer to show up into clinic, and they'll kind of randomly pop up 4 months, 5 months down the road. And of course, we never turn them away, and we want them on treatment at any time. But unfortunately, no, I don't have an exact number. I think down the road, as we as our numbers have really grown and as our database has grown, it's definitely something that we need to start compiling so that we have these more solidified numbers to share with everybody.
Okay. Those are our questions. Thank you very much.